how DPP4 inhibitors work, by action of DPP4, active GLP-1 pool is constantly degraded into inactive pool. Within a minute and a half to two, this GLP-1, whatever is secreted, gets degraded. So by blocking this enzyme, they convert a large inactive pool into active pool by blocking the degradation of GLP-1. And that is how DPP4 inhibitors act. And we have 3 molecules available which act by this mechanism, and I'm sure you all are using these molecules. Contraindications for incretin mimetics are end-stage kidney disease, pregnancy, and gastrointestinal disease. But DPP4 inhibitors now, vildagliptin and sexagliptin, have been shown to be safe in using mild to moderate renal impairment. Liraglutide again is under scanner because of the increased risk of pancreatitis and some increased risk of thyroid C-cell cancer. Now there is another drug which has become available last year, May 2009, is bromocriptine. Now this is one mechanism which is again a novel mechanism which is being addressed by this molecule. What happens in diabetes patients, there may be low morning levels of hypothalamic dopamine. So morning surge of dopamine may be, blunted. And this may be leading to increase in central component of insulin resistance, leading to hyperglycemia and dyslipidemia. Cyclosat is, quick release bromocriptine preparation, which is now available as various brands in India also as Brainstar or Glucomine and Protein or something like that. So this resets the aberrant morning hypothalamic activity, leading to resetting of neuroendocrine metabolic control, leading to decrease in insulin resistance, decrease in postprandial hepatic glucose output, and decreased lipolysis. So what happens is, once there is low dopaminergic activity, there is increase in sympathetic tone, there is increase in HPA axis tone, increased hepatic gluconeogenesis, increased free fatty acids and triglyceride levels, increased insulin resistance, and a pro-inflammatory state. And there is, all in all, impaired glucose metabolism, hyperglycemia, insulin resistance, and adverse CV pathology. By giving this dose, now this dose gives a 65% release within 2 hours. So this dose needs to be given 2 hours prior after the wake-up time. And that's the time when you need a peak of dopamine. And by giving this, you have restoration just 2-3 minutes. Restoration of morning peak of dopaminergic activity, which is mediated by D2 receptors, leading to reversal of all these effects which are resulting from low dopamine levels and improvement in insulin resistance, hyperglycemia, and dyslipidemia. And these are the data from study where it was shown that 35 to 40% patients who were failing on oral anti-diabetic agents reached A1C targets after addition of cyclosat. And there is some data which is very promising that it also helps in reducing weight. The important thing is it is to be taken within 2 hours of waking time, and dose is 0.8 milligram tablet, which is to be up titrated up to 6 tablets daily, given at the same time. There is another class which is coleselvum. Mechanism of action is uncertain but leads to about 0.5 to 0.8% reduction when used in combination with metformin, sulfonylurea, and insulin, and it also causes significant LDL reduction. It has to be taken with meals or liquids, either 6 tablets daily or 3 tablets twice daily. The dose is large. No special consideration or dose adjustments are required, but there are contraindications if there is a bowel obstruction history because it causes severe constipation. There is, if the triglyceridemia is pretty high, or there is history of hypertriglyceridemia induced pancreatitis. There are a number of drug interactions with this molecule. Major side effect is only constipation. Now, we know that there is progressive decline in beta cell function with time, and most of the patients 5 to 7 years or 10 years down the line will need insulin and fail on oral agents. And this was UKPDS data. Even within first year, almost 20% patient needed insulin. Now, all the agents, they lead to A1C reduction anything between 1 to 1.5%, not more than that. And it is only insulin which can be up titrated to give you a customized reduction, say even 4% or higher than 4%. Even the combination therapies don't give you a A1C reduction of more than 3 to 3.5%. Once you are combining, so there is, frequently a need to combine 2 or more agents. So once you are combining 2 agents, you should look at the glucose lowering potencies of these molecules and also look at the synergies involved when you are combining. If you look at this graph, this is the line which is showing insulin resistance, and this is showing the graph decline of the beta cell function, and this is translated by increase in glucose levels. So all patients need to be given medical nutrition therapy and lifestyle changes. All patients should be on insulin sensitizer because insulin resistance rises and stays permanently. In addition, they will need secretagogues or maybe DPP-4 inhibitors here. And once the insulin secretion falls below a critical level, possibly all of them will need to be put on insulin sometime during the course of therapy. Now, after this, Dr. Kennedy is going to take up the insulin treatment. I will just take you through the algorithm for management of type 2 diabetes. This is the current consensus algorithm which is recommended, that at diagnosis all the patients should be started on lifestyle management as well as metformin. And down the line at 3 months, if they are not able to achieve target A1C of less than 7%, you can add drugs from well-validated core therapies or drugs from less well-validated core therapies. So well-validated core is now includes only basal insulin and sulfonylurea. If you are able to achieve A1C, fine, otherwise combine the second molecule from this. But it does not mean you use only these. You have the option of using other molecules which include GLP-1 agonist or glitazone or possibly DPP-4 inhibitors or alpha-glucosidase inhibitors, and possibly down the line the guidelines are going to include other molecules which have become available. The target A1C needs to be achieved. How you achieve that is less important, but it is more important to achieve that target. With that, I think I will close my presentation and invite Dr. Kennedy to move on with the insulin presentation.